Dr. I might pronounce your name wrong. I apologize, Junqueira. If you just want to introduce yourself before starting your presentation, but go ahead and start.
Thank you very much. My name is Matheus Junqueira. You can call me Matheus or Junqueira. I'm a third year resident of the general surgery program here at the Hospital das Clínicas of the University of São Paulo in Brazil. And I'm bringing a case of a 62 years old male. He fell from a 4-meter high into a construction site with a transfixion neck injury. At the scene, he was stable, as you can all see from his vital signs. Actually, he was so stable that he himself called 911, said he needed help. Then he cut the iron rod himself, and after that he called his son to tell him that he was okay. But he was intubated from the transportation. He was flew from helicopter to our hospital, and the total time of pre-hospital care was 60 minutes. At the trauma room, the primary evaluation, he had no external bleeding. His airway was secured by the endotracheal tube with no other alterations. His ventilation was all right and had no alteration in the thoracic exam. He remained stable macrodynamically and had no alteration in the examination of the abdomen or pelvis, and his EFAST was both negative in the thoracic and abdominal windows. Regarding the neurologic...
Excuse me. Could you pause for a minute?
Yes.
Can I ask you a
sure.
question? So he was able to call up his son and give him some command, and he did all those things you mentioned. Could you tell us why he was intubated at the scene of the accident?
Sure. He was going to be removed by helicopter, and the helicopter here is a very small vessel, very small ship plane. I don't know, and because of the injury, the pre-hospital care team was with the thought that was better to secure the airway that taking the risk of bleeding that could endanger his airway through the flight if he wasn't intubated.
Excellent. Thank you. Carry on.
Okay, so he was sedated. So regarding the neurologic examination, at this point we had no other informations. And regarding the exposure, his injuries. I believe the images speaks for itself. So he had an iron rod transition from the zone 2 of the neck just before the chin anteriorly and going all the way posteriorly near the occipitius in zone 3. He had no hematomas, and through the injuries, through the wounds, he had no salivation or air fistulas. Now I leave this moment, I separate this moment to discuss whether we should take the patient straight away to the ER, the OR, or remove the iron rod in the emergency room, or should we take him to the CT scan room?
Dr. Untrak, what are your thoughts when you see something like this in the trauma bay?
Okay, so my thought and my team thought was that this patient had a obvious indication for surgery. So he didn't have hard signs of neck penetration trauma or soft signs. Actually, he has one sign that is the object has a dangerous uh, path through the carotid sheath. So besides that, he had no other soft signs. So, but besides this indication of surgery, you will need to pull the object in the OR to control eventually some bleeding. But apart from that, he fell 4 meters. So this is a very dangerous mechanism of trauma, high energy mechanism. So as the patient was stable, we choose to took him to the CT scan. In our institution, we had a protocol of full body CT scan guided to trauma.
Dr. Untrak,
Yes.
what do you
So,
think?
yes, really a fantastic case. It's very simple and straightforward, and it's one of those unusual cases where you see an arrow and here or there, but you can see in that last photo that you showed. There you go. You see the entrance wound and the exit wound looks like it's near the occiput. And you can probably feel, I'm guessing it's subcutaneous. And the issue is, I agree with imaging. The issue is how good an image can you get in CT scan with rebar, the reinforcing bar there. And you say no hard signs. He's already intubated. It's good. I think it was a perfectly, as Dr. Cassim agrees, perfectly reasonable, in fact, an excellent judgment call. Was there a doctor with the helicopter or the paramedics? Your paramedics just made that decision.
No, was the team that flew all the helicopters here had a doctor.
A doctor. Okay. Yeah, a really excellent judgment for a 1 hour transport. And, I would say in this case, it's reasonable what you did. We'll see how good the images are. My inclination would be, depending on how good an image you can get, is probably, if you have access to interventional radiology, do a formal angiogram and then see, is there any injury to the carotid? If there is, whether they can stent it before the OR, whether that's a reasonable thing to do. If there's no injury of the vessels and no fracture of the skull, I agree with going to the operating room to be prepared to open the neck while you remove it. But if there is no injury, then I would first do a esophagoscopy and to rule out a pharyngeal or esophageal injury. And if everything looks good, and you'll be able to tell if there is a carotid or a jugular injury in the X-ray suite, then I think in the operating room you can remove it without making an incision and be prepared to make an incision. If it just bypasses everything and pushes the great vessels away, fine. Otherwise, you need to expose the great vessels and get proximal and distal control, then remove the piece of iron and do your repair.
Dr. Rodriguez, good morning, sir.
Good morning. I thought I was not part of the Three Musketeers there. You guys eliminated. But anyway, fantastic case. It sounds like like not like a Brazilian soap opera, but like a Mexican soap opera. The guy walk out, get the phone. Cut. You say he cut himself the road. That sounds a fantasy island, no? And called his wife and called the ambulance. I mean, the only thing you didn't say, he intubated himself. But is that real, doctor? It's like he was doing a lot of things with that thing crossing his neck. One thing we know for sure, 100%, that nobody will pull his cowboy boots and trying to pull this in the emergency room without doing anything. So we all agree in that part. The second is the intubation, and I agree. I didn't know the Brazilian has like the Argentinians doctors and the helicopters. In the United States, there is no doctors in the helicopters. There is paramedics who, other than the pilots, who maybe they are probably there are so many of them can intubate the patient. But anyway, that part is okay. But then the discussion is the CAT scan in this case. Oh, by the way, just for the residents, seems like the new management of penetrating trauma of the neck, they call it now the no zone. I don't know, we can discuss that. You allow me, Dr. Kasim. They don't go like we were doing in the old days, zone 1, zone 2, and zone 3.
Right.
That's the way, actually, when I came to this country, it was not even that. It was anything who penetrated platysma, you had to open. I came here in 1971 to the United States. And that went away. Then come the zones, 1, 2, and 3. And then now seem like they don't care about the zones. They go more about the clinical aspect, particularly this bleeding, you put your finger, you put Foley. And then they come the point, the CAT scan in this case, like it's in bullets, sometimes first it's difficult to put in there. Second, be a lot of artifacts, with this thing there. So here, Doctor, I never can pronounce your name. I'm sorry, Doctor, the other doctor. He suggested the old way, angiogram and maybe esophagoscopy or something like that, because that would be more likely to indicate if the carotids are okay or not. That's what's going to add. Thank you.
Dr. Calderon, I see your name there. Would you like to participate?
Hello,
Yeah.
can you hear me, Dr. Kasim?
Yes, we can. Go ahead.
Yes, hello.
We'd
Let
love
me
to
go
hear
to
from
some.
you.
Yes, I showed up late to the meeting. I can see this. I understand this is a patient who fell from 4 meters, right, and has an impalement in the neck. So, yes, the most obvious lesion is that penetrating injury to the neck. We're trying no longer to use those rates. So those zones 1, 2, and 3, but instead of that, to pay attention to if there is any hard sign or soft signs of vascular injury. As I understand that this patient already has the airway secured and there is no obvious hard sign of vascular injury. So if the patient is stable and the airway is secure, I would take a moment to take the patient to the CT scan. I don't forget that he fell from 4 meters. He can have any other injury in any other side of the body. I would scan him, brain, neck, chest, and abdomen, pelvis. Checking there is no other injury, and also I could have a CT angio of the neck and brain. It could be very useful for surgical planning before taking the patient to the OR. That's all I have by now. Thank you.
Very good, doctor. You brought out some important aspect of this case. It is just not the head and neck. We need to also look at if he had a subdural or something like that, and also he may have, 2 cavity or 3 cavity injury along with fractured femur. Who knows? He may have broken something in the leg as well. But one thing for sure, he is able to talk and give command, so his airway is intact before we deliberately intubated him for very good reason, because you don't want any drama in the small helicopter that is transporting him from point A to point B. Okay, go ahead. So what did you do?
Okay. then we took him to the CT scan. I'm sorry. First, we take the regular measures at the trauma room. So venous access. We started him on antibiotics. Considering that he could bleed in the following moments, we gave him tranexamined acid and took him to the CT scan room. So we had these. We also had this worry that the rod, the rebar, could difficult the imaging, but we took him to the machine anyway. This is the lab test that the patient was took from the patient just when he arrived. So we can see that even the microhemodynamically he was also stable. This lactate here, I'm sorry, I forgot to translate the last letter to the English, but here is very close to the our lab parameters, so is near normal. This is the scout from the CT scan, and now I will show you the imaging. I took only the imaging from the head and neck because the rest of the imaging, the examination was normal. So he had no injury to the chest or the abdomen, had no pneumothorax or hemothorax. So we can see that the rebar do some artifacts who difficult the interpretation of the image, but we can see that is nowhere near the esophagus, and the airway is like a little bit distant from the trajectory of the rebar. And I'm gonna to show again how close it is from the carotid and jugulary vessels. So I'm sorry. So here we have the jugular vein, the carotid artery, and this is a little bit difficult to show in this mode. Is better way is easily looking in the computer, but is right in the trajectory of the carotid sheath. So moving forward. Now, I separate this moment to discuss if the tactical aspects of the surgical approach, if we should incise the neck or do as our colleague here said, that just pull the bar, or we should incise the neck and maybe give some approach in the thorax, considering the proximal control. What you would do?
Dr. Rodriguez, would you like to start? What would you like to do with this case at this moment?
I pass to my friend from case who live in Iraq to give the first. Go ahead, doctor.
Well,
Dr.
you know, I think either way would be reasonable. You can see that basically it passed and it missed the great vessels. I'm trying to think what else can be in the area, but what I think either way would be acceptable. What you'd worry about are small peripheral branches that might form a hematoma if you simply pull out the rod, and it may not bleed early, it may bleed late, and you want to, that's all possible. So if you decided to go ahead and remove it under direct vision, inspect the track, and that would be, if you decided to operate, that would be what you'd have to do: expose the track of the rebar, reinforcing bar, and then pull it out, looking at the wound under direct vision, and stop whatever happens to bleed. I mean, that would be reasonable. Rinse it out, close the neck, do a nice job. I think that might be the conservative approach. What I might do in this case, and I have a similar case of a rebar that popped through the bottom of a vehicle when they were during road work. That patient came in taped to a chair, everything with rebar going up his back, and it was all subcutaneous, and it's kind of fell out in the ER, and he was fine. There was nothing bleeding. So the other option is go to the OR, do you ruled out aerodigestive injury, although a lot of air in the soft tissues, I guess, introduced outside in, but not from inside out. So that's okay. And then watch them carefully and listen for bruits and see if you have any swelling. If there are any swelling upon removing it, then go ahead and open and explore the track. I mean, either one, I suspect that probably, I'm guessing that you made an incision, because if you pulled it out and nothing happened and you went to the ward, we'd be done now after 10 minutes discussing this case. But I might be tempted to go ahead, pull it out, watch them carefully, and maybe repeat the CTA, looking for blushes, whatever, to be sure that everything's going to be okay, and call it a day at that point.
Now I'd like to intervene. Stephen, that's why I'm going to remember your name, Dr. Stephen.
Yes.
I think I agree with that. I will pull the thing in the OR, again, and repeat this issue. Nothing is going on unless there is of air. I didn't see bubbles of air in the first CAT scan. Otherwise, I'm obligating me to do endoscopy or something like that, and repeat the CT, and see what it is. Maybe this guy is related to the Peruvian Pope. I don't know. Americans get very upset because Peruvian. He says American. He was born in Chicago. Yeah, he wants to be
Chicago.
Peruvian. Anyway, so that's what I would do. And now Dr. Cassin, what would you do?
Well, interesting case. Several years ago, Dr. Supra from Bangkok presented something like this. And apparently in Bangkok, they have industrial, wire cutter. I'm talking about, these are, they actually can cut a lot of stuff. And this rebar obviously is not amenable to slicing at the entrance or exit, whichever direction you want to shorten with impunity. I don't think such a thing will be available in this part of the world. So that would be out. The second thing is, I think before I decide to extract the impalement, I want to be sure in my mind that I will not cause any harm to the patient. So if I had any doubts about it, I wouldn't mind doing a small sternotomy or, sternomastoid incision to expose the vessels, especially the carotid, where I can put a bulldog or a clamp temporarily to see what happens once I pull the rebar out. And if that is not going to happen to me, if that's not possible for me to do that, I think I would have at least a Foley catheter available for me in case it gushes a lot of blood once I remove the rebar. And they do that in South Africa quite frequently I'm told, I have a friend of mine who works in Cape Town, and they say they get knife wounds like that in the neck, and they use Foley catheter generously without any impediments. So I think what I would do is I probably will go with having some type of Foley catheter or some other catheters available for me so that I can pull this out and pass the Foley catheter and inflate the balloon if it started gushing a lot of blood, and then hope for the best. And that's what I would do, Dr. Rodriguez. Thank you.
Thank you, Dr. Junqueira. I have a question. How they cut this? You mentioned that he cut it himself. It doesn't make any sense. How they cut it there in the field, or he was in a small hospital where they cut this too?
He cut it with a saw, with a
Who cut it? He kind of cut it.
himself. He was working with his
No.
brother.
He's no Pelé, okay? He's no Pelé. That he's not taught that he can do that kind of thing.
He cut himself. His brother was too nervous to cut, so he asked for his brother to take the saw and himself cut the bar.
He could go to orthopedics or something like that, you know?
Wow.
I don't know.
He was smart enough not to pull it out.
Yes.
Oh, well.
Yeah.
Yes.
He probably worked as those guys in the construction who put those wires in the building, you know. So he was familiar with how to cut these things, I think. And know anybody
Yes.
an idea what to do with it.
Yes, he was working at the site.
One thing I would do before I embark on anything else, just to be absolutely sure, I would do either a flexible or rigid esophagostomy since he's already intubated to reassure myself there is no injury to the esophagus, even though the CT scan does not show that, just to be absolutely sure. And then you already have a ET tube in the trachea, and you can either slip in a bronchoscopy or whatever you want to do, just to make sure that, again, there is no posterior tear or lateral tear or anything like that. And you have to do some pre-extraction work to assure yourself that you're not going to overlook anything and you're not going to cause any harm to the patient.
Well, let's agree on something. Before we send this patient home or something, we have to do, as you said, an endoscopy. Be sure the esophagus is okay, do a bronchoscopy, and repeat the CT with angio. You know, I think if those three things are normal, then the be an excuse, we can send this patient home. But we can. I think this patient willing just send it home next day if everything is negative. You know, for sure.
Dr. Calderon, would you like to say something?
Hello, yes, but what else can I say? Yes, where I am, we already have a vascular surgeon 24/7, and we will have a head and neck surgeon the next morning. So I would say that maybe most of these patients will wait for the next day to have those specialists, or especially the head and neck surgeon available. But yes, it will be better if the rod is pulled out in the operating room, being ready to repair any vascular injury or airway injury. Yes. It would be better if we can do the upper GI endoscopy or bronchoscopy in the operating room during the same procedures.
Dr.
Pardon me?
Where are you located? Where do you work?
Doctor Rodríguez.
Sí, ¿dónde trabaja usted?
Lima, Peru.
Oh,
I work in the south of Lima.
Which hospital do you work? ¿Qué hospital?
This name is Hospital de Emergencias Villa El Salvador, que ya pasó a llamarse, called only Hospital Villa El Salvador. It's in the south of Lima.
He's my countryman.
Yes, I know. I sent you a message. Dr. Cassin,
okay.
Can I share my screen just for a moment?
Sure. Oh, yes,
Oh, I'm not
yes,
allowed. I'm not allowed.
Kevin.
Yeah,
Yeah,
yeah.
I have
Now
a
you can.
question. I
Yes,
don't
you
know
can.
what the group feels about this. I have bad feelings. There are circumstances
Oh, there
like
you are.
a bad liver injury that I call somebody who do transplant or something like that. But I have bad experiences when you call very a lot those specialists, we call it, vascular surgeon, because they see the trauma patient as a different way we see, They start seeing,
Yeah.
there was a discussion here that they call a vascular surgeon, a vascular lesion a few days ago, and he basically told the doctor who presented that he was totally wrong, had he did wrong, he criticized it, and that was wrong, this is the specialist, So I don't know what's the feeling. You have to be careful when you call this a specialist, we call it, because they don't see trauma, they see the thing different way.
That might be true, Dr. Rodriguez, and that's one of our fears. Where I talked to other general surgeons in Peru. The problem with the vascular surgeons sometimes is that they want to do what they are trained to do. It means they want to do definite surgery. Do you the graft, vascular graft, TFE, whatever, sometimes in a patient that is not stable enough. And the patient, they take too time, a long operation for a patient who is not physiologically ready, let's say. So that, yes, that happens. That's what happens most of the time, I would say. Slow decisions and sometimes trying to do a long surgery in a patient who is not ready for that. But, okay.
Thank you.
Dr. Matthias, would you like to carry on?
Could I just add something before, just very quickly?
Sure.
Yeah,
Go ahead.
I want to second what Dr. Calderon just said. I still remember a case that Dr. Alon Schwartz presented from Tel Aviv, and it was a horrible injury to the duodenum and pancreas, and the patient had been in shock and lost a lot of blood, and he got everything stable, and then he made the mistake of calling in his gastrointestinal surgery colleague, who insisted that Dr. Schwartz go ahead and do the definitive operation, a complete Whipple, reconstruct at the time, and the patient never recovered from a shock and died very clearly as a result of an imprudent long operation. So this is not just in South America; it's in North America. I can tell you from and also in around the world. So it's okay to call an expert in, but and just take the information and don't let them, especially with limited information, with just seeing the one small part coming in after you've done your evaluation, just keep control of the patient and do the right thing.
Perfect.
Great advice.
So carrying
Dr.
on,
Matthias, go ahead.
we took the patient to the OR. So we, at the OR, we prepare for the worst. So they include the neck, the thorax, and the thigh in the operative field. If we needed to take a Safina vein graft. So this is the video that we took from the surgery. We choose a wide anterolateral cervical incision. And we started to dissect to the carotid sheet in here, in this view. We already see the carotid sheet open and the jugular vein here in the blue vessel loop. And the common carotid artery is in the red vessel loop. Then we proceed upwards in the direction of the vessels. So in this moment, we had already gained control of the proximal vessels, but we figure out that probably it was okay. So the bar was insinuating very high in the neck. So if we had chosen to gain the distal control, we would have to luxate the jaw. So we prefer not to do this. So we got the proximal control, and we got ready some Fogarty catheters that we could insert in the lumen of the vessels in case of a major bleeding. So proceeding with the video, and here we are manipulating closely to the parotid gland, so the tail of the parotid gland. So this is important a little bit. And here we see where the rod passed. So here is the internal branch of the carotid artery, and the external branch of the carotid artery is just behind the bar. So it got through the two branches of the carotid artery. Here we already had the impression that had no total damage to the wall of the vessel, so we had no perforation, but the vessel was like bluish and had some angle, and so we got worried that could be a thrombosis of the vessel. Sorry, pull the video out. So in here, we are starting to give some constant traction to the bar to pull it out. So here we go. And
You're
as you
afraid.
can all see,
Wow.
it did not bled, so
No
everything
bleeding.
was okay. Now we can see the external branch of the common carotid artery, and the internal branch remained with that angle. So we drained the incision because we had manipulated closely to the parotid artery, parotid gland. So we got worried with salivary fistula, and then we are closing the incision. This is the final aspect just before we suture the skin. The final aspect of the field just before, just after we took the bar, the surgical spasm, and the aspect of the incision. After the surgery, the patient remained stable. He had no bleeding whatsoever in the operation. The immediate postoperative care, the neurosurgical team, I forgot to mention, but he had a small transverse process fracture of the C1. The neurosurgical team in this moment rule out the need of cervical immobilization because the fracture was stable, and gathering the informations of the surgery and analyze the imaging we took earlier. We got the fear that the internal carotid artery was thrombosed. So we choose to perform a new CTA before the extubation. So the common carotid, and just after the bifurcation, we lose the contrast in the internal carotid artery. But as you can see, the Willis collateral arteries are fully contrasted. So, and the imaging show no signs of ischemia in the brain. Just a sec. So with this information of the thrombosis, should we do something about it? We should take the patient back to the OR and perform some vascular procedures, endovascular procedures, or open repair, or just aspirin. What do you think?
I have a question for you.
Sure.
After you removed the rebar, did you do an intraoperative Doppler examination of the carotids, all three branches, common, internal, external?
No, we did not perform the intraoperative Doppler, no. Neither we perform angiogram, just only the CTA.
Well, Dr. Untrak,
Yeah,
what
so
do you think?
yeah, so you had thrombosis of what? The right external carotid, say again, where the thrombosis was?
The right internal carotid artery.
Okay, and then and then there was adequate collateral flow?
Yes.
The Willis was intact, you said, right?
Yeah, yes, okay. So you had the middle cerebral artery on the right side. It was patent, basically. Yeah.
Yes.
I would ask for this. I think it's okay to ask the vascular person because he's okay as long as the left side stays open, and he's 60 something, right?
62.
Okay, and he hasn't, so he's older, and you worry if he were 20, and then by the time he's 45, he's got a lot of vascular disease, and then he just, occludes the left side, and then the right side has been gone for years. I mean, so for this, I think it's okay to add, this is a non-trauma related question, so I would ask them, but, and then pass the case over, whether maybe they can put streptokinase or tenecteplase, direct angiographic injection, and see if it recanalizes, or do they need to go in and it's a pretty safe thing to do a thrombectomy of the internal carotid if he has good flow across the circle of Willis. So, I would run this by them, but I would be more, at least, I wouldn't make the decision myself. I'd be sure to call the carotid vascular specialists and see, what to do here, So, yeah, I would leave it that way.
I
Dr.
agree.
Mataris, there's a chat question from Doctor from Japan. He's asking whether you gave any anticoagulation to the patient.
No. At this point, we had not started any anticoagulation, neither before the surgery or during the procedure.
I don't think there was a role of anticoagulation before you see this bluish thing and that like that, because you were trying to figure out, hopefully there was no injury. But anticoagulation could be, as Dr. Stephen said, it could be one of the ways to treat it. But I agreed also 100% that I doubted there is any surgeon who say, oh, I saw 10 of these cases, so I do this way or the other. So I really asked for a second opinion for a vascular surgeon. I selected the one who I think is a smarter one. He probably will do him. If he's aggressive, he will probably say, I will do endovascular, remove the clot or to put the substance we are mentioning. And the other option, of course, is like we do with the vertebral arteries injuries, we do anticoagulation, aspirin or whatever.
Dr. Calderon, would you like to contribute?
But yes, but it's the same. I would defer this very difficult question to a vascular surgeon or interventional radiology. In some places it's neuroradiology, and they would choose just conservative treatment with anticoagulation on the aspirin or endovascular treatment. I will defer the question.
May I contribute something to this? My teacher told me, when you're sitting on a winning horse, don't get off. I think you're sitting on a winning horse here. The patient is asymptomatic. He's doing great. Everything looks good on the CT scan. And you're worried about the thrombosis of the internal carotid artery. I'm pretty sure that he has a collateral circulation from the opposite side, and he's functioning, his brain looks intact. And I would not go and do anything more to this patient other than perhaps give him low dose aspirin and watch it. In my experience, I've had a couple of cases where leaving the thrombotic vessel alone sometimes get recanalization by itself. Nature does a very good job of reboring that vessel, and surprised that you for one reason or the other, you go and do an angiogram few years later, and lo and behold, you see flow in the vessel, and you're surprised. So this patient is extremely lucky, and nature has been very kind to him, and the surgeons have been super kind to him in salvaging him. And I think I would not do anything further than giving him a low dose aspirin and watch him for several years. Dr. Matthias, would you like to conclude now?
Yes.
Do you have anything else to say?
No, we had some similar thoughts. So we asked vascular surgery for evaluation, and they concluded with in common discussion that no new surgical procedures were necessary. So we just gave him aspirin. He was successfully stubed in the OR. He was transferred for the CTA, then got back to the OR, then was admitted to the ICU for postoperative care. We didn't perform the endoscopy or the bronchoscopy. We started him on diet. In the first day of postoperative, he took the diet very well. Had no vasopressors, no oxygen support, no neurologic deficits, and we suspended the antibiotics in the second day of after the surgery, and he was discharged from the ICU in the second day after the surgery. Here are videos showing that some tests showing that he had no neurologic damage to the axillary nerve, and here his feet showing that he had no neurologic damage to the territory of the cerebral artery, median cerebral artery. In the 5 days after the surgery, we removed the drain and discharged him from the hospital. And to this day, he is all right. He got consultations with us, and he is asymptomatic. And he follow also with the vascular surgery, and no other further procedure was necessary.
Except that now he speaks Spanish. You forgot.
Yeah.
Mhm.
You know, Brazilians don't like when we speak Spanish in Brazil. They say either Portuguese or English. But when they come to South Latin America, they say, we speak Portuñol, which is a combination with Spanish and Portuguese. We love you, Matthew.
Thank you.
Dr. Suntrak, do you do a summation?
Yeah, great case. So, looking at this, and remind me the name of the Portuguese surgeon who does everything but cut with a scalpel. What's he usually has attends from a big room with his whole department behind him. What's that surgeon?
Oh,
Cervini?
No, starts with a C, I think.
Cervini.
Huh? No.
Cervini. This is
no.
The one that does non-interventional treatment of you know, grade 4 liver lacerations or grade 4 spleen. But anyway, you know, in this case, I think it's an excellent example of these kinds of injuries and the way they just, these impalements, they tend to, these, especially the blunt ones, they tend to push the nerves and the vessels away, so that that arterial branch, it just pushed it anteriorly, and you know, it didn't cut through it. And bullets, I think, sometimes do that also. But you know, great example of that. And it, you know, as surgery evolves, now, you know, surgeons don't do laparotomies anymore. They do everything robotically. You know, talking to some of the young surgeons around where I live, that's what they're doing, and you know, for good reason. And I think going forward, for some of these cases, especially if you have a hybrid room, the one possible way to manage this is to take the patient to the hybrid room. You know, he's already intubated. I would still do the scopes, you know, initially, and then remove, you know, remove the foreign body, and then immediately do an arteriogram. And if you're concerned about a bleeding vessel, you know, you can embolize it or stent it if it's peripheral. You know, you would see immediately the thrombosis. And if there's an easy way to deal with it definitively without being meddlesome, you know, if they say, okay, give me some tenecteplase, I'll just inject, you know, 2 mLs, and that'll accelerate the opening up of the vessel, and just leave it at that, you know. And that's a way to avoid that beautiful incision that you made that healed nicely. And I think he'll like going back to work and showing all his buddies, see right here where I fell on the rebar. So, you know, but that's an alternative way to manage. But I think what you did was superb. It was excellently done, and you got a good result. The other thing is, you know, that contracting company, they have a rule against going off site with the construction materials, and they want that rebar back. That's a perfectly good bit of rebar, and they can
Dr. Rodriguez.
It's an outstanding, Dr. Kasim, by the way, a very nice mastering of this. You were the moderator. Dr. Kasim, last question for you. Where are you from, Dr. Kasim? I have been crazy.
I'm from Portland, Oregon.
No, but originally, where are you from?
Oh, I came from a country called Myanmar, which is way out there. I came to study on a scholarship to England,
right?
And then from there I migrated.
Very good, thank you. Wonderful management of this case, Dr. What was the name of the present representative? Junqueira. This case is unique, you know. I mean, this is a very. This guy is so lucky. I don't know how to call it. I think the physics. Maybe we had to apply quantum physics to explain how the hell this thing went. It didn't hurt anything. So this is called Lucky Man. You know, that'll be his new name. Thank you very much. I think the case fantastic, and it should be presented. Well, it was presented. This is the top, right? The AST, the Pan American Trauma Society meeting. It was a very good case. Thank you. I learned how to know necessarily a lot means a lot. Sometimes a lot not be. You use your common sense, like Kasim always used, and Dr. Stephen and you, the patient, is doing very well. Fantastic.
Dr. Calderon, thank you for participating. Give us the final perm.
Yes. Well, this was an excellent discussion for a good case of a penetrating neck injury in a stable patient, and a good talk of all the precautions we can make. There was no need to rush. And the last image, this is for Dr. Aurelio Rodriguez, because today is our national day, Peruvian National Day.
Yes, today.
Feliz día, Dr. Rodriguez.
Yes, Dr. Calderon, what medical school you went to?
En Perú, Universidad San Martín de Porras, posgrado San Martín,
You sound very good for all the Peruvians I know. You have very good. I am from San Marcos, but San Martin de Porres is very good, very good. And where do you learn English? Because you speak better English than I do. I've been 40 years here. Where do you learn?
From very young, since we have English lessons at grammar in kindergarten, grammar school, high school, and I spent 2 years in the USA. So.
But where was that? Which school was that? Peru.
Peru.
I don't see you follow my. But anyway, thank you. I'm honored for you, Roberto. You're very good. Thank you.
Good day.
Well, thank you, Dr. Matthias. Thank you for presenting a wonderful case. Your presentation was excellent, and your team managed this case very, very well. You couldn't have done anything better than what you have already done. And then you saved the patient's life. Thank you again. And thanks for all of you for participating. And Dr. Carlos will be here next week. Hopefully he will be the moderator. Thanks. Thank you and goodbye.
Thank you.
Thank you for moderating, Dr. Kasim. Everyone have a great day.
Thank you.